Okay, let's talk varicose veins. Now, I know what you're thinking. How complicated can it be, right? But trust me, this topic is packed with clinical details that are absolute gold for your NEET-PG exams. So, in this explainer, we're going to break it all down. We'll build the whole clinical story, piece by piece, from the very first signs all the way to the cutting-edge treatments. My goal here? To make this the only deep dive you'll ever need on the subject. Ready? Let's jump in.
So, believe it or not, we're actually going to start at the finish line. What you're looking at here is a C6 active venous ulcer. This is the absolute end stage of chronic venous disease when it's left untreated. It's pretty brutal. And this is exactly what we, as future surgeons, are trying to stop from ever happening. To really get a grip on how to manage this, we've got to go back to the beginning and understand the whole story. So, let's hit rewind. All right, here's our game plan. First, we're going to learn to speak the language of venous disease. That's the CEAP classification. Then we'll meet our patient, who gets this and why. After that, we dive into the diagnosis with the gold standard Duplex ultrasound. Then it's the main event, modern treatments versus the classic open surgery. And we'll wrap up by talking about what happens when veins come back, recurrence. Okay, Section 1, the CEAP classification. So think of CEAP as the universal language for venous problems. You absolutely have to know this, not just for your clinics, but because, well, the examiners are obsessed with it. Let's get into it. So what does CEAP even stand for? It's clinical, etiological, anatomical, and pathophysiological. Basically, it tells the entire story of the patient's condition. Now, for your exams, you should know what each letter represents, but let me tell you the highest yield part, the one they will definitely ask you about, is the C, the clinical side. So let's really zoom in on that.
Let's walk through this because it's really a story about rising venous pressure. It all starts pretty quietly. C0 means no signs at all. C1, you just see some of those little spider veins. Then, bam. C2, that's when you have full-blown visible varicose veins. By C3, the pressure is so high the leg starts to swell with edema. C4 is a huge turning point. The skin itself starts to suffer. You get pigmentation, eczema, and this tough, leathery hardening called lipodermatosclerosis. And that's the slippery slope to the end stages. C5 is a healed ulcer, and C6, well, that's the active ulcer we saw at the very beginning. And a quick side note, for any of these stages, you add an S if there are symptoms and an A if there aren't. Simple as that.
All right, Section 2, the patient. So let's take that classification system and apply it to a real person. Who actually walks through the door with varicose veins? What are the risk factors? And what are they going to tell you is bothering them?
Okay, so these are the big ones. It's definitely more common in women, and it's strongly tied to getting older. I want you to look at these numbers from the Edinburgh Vein Study. This is a super important study, by the way. The prevalence just explodes from around 11% in young folks to over 55% in the 55 to 64 age group. That is just a huge leap. Then you throw in things like pregnancy, family history, and a higher BMI, and you've got your perfect storm for varicose veins.
So what does the patient complain about? It's usually this vague, hard-to-pin-down feeling, an aching, a heaviness, maybe some throbbing. But here is the single biggest clue you'll get from their story. It gets worse and worse as the day goes on, but it gets so much better when they put their feet up or wear compression stockings. That right there is your classic venous pattern.
Now, when you're examining the patient, you have to be on the lookout for this one specific sign, a Saphena Varix. This is a soft lump in the groin that literally disappears when the patient lies down, and you can feel a thrill when they cough. Okay, now listen up, because here is a classic NEET-PG trap alert. The examiner is going to try to make you think this is a femoral hernia. They love this question. The key, the absolute differentiator, is that watery, fluid-like thrill you feel on a cough, and the fact that it just vanishes completely when they lie flat. A hernia just doesn't do that.
Section 3, getting the diagnosis. So you've got the history, you've done the exam. What now? The answer is simple and it's non-negotiable. Duplex ultrasound. This is the mandatory, absolute gold standard investigation you must do before you even think about intervening. All those old tourniquet tests? Forget them. They're history.
And how you do the scan is so important. The patient has to be standing up. Why? It's all about gravity. You need gravity to pull the blood backward to show the reflux. That's the whole problem, right? Blood flowing the wrong way. If you scan someone lying down, you could easily miss it completely. So standing up, it's absolutely non-negotiable. When you get up to the groin, you're looking for this classic landmark. Everybody calls it the Mickey Mouse sign. You see it? The common femoral vein is the face. The common femoral artery is one ear. And then medially, that's the great saphenous vein joining in. That's the other ear. This is your fundamental view, your anatomical compass in the groin. Okay, as you follow that great saphenous vein down the thigh, you'll see this beautiful image, the saphenous eye. See how the vein is perfectly nestled inside its own fascial compartment? It's sandwiched right between the superficial saphenous fascia and the deep muscular fascia. This is how you know for sure that you're looking at the true great saphenous vein and not just some random branch.
So, this is the money shot. This is how we prove the valves have failed. On the spectral Doppler, just watch. We give the calf a squeeze, and you get that sharp blue spike. That's good, that's blood flowing the right way up towards the heart. But then, we let go, and look at that long, angry red signal. That's blood just tumbling backward down the leg. That is reflux. Okay, time for a memory flash. Pathological reflux is officially defined as backward flow that lasts for more than half a second in the superficial veins or more than a full second in the deep veins. You have to memorize those numbers.
All right, Section 4, Modern Management. Now that we have a solid diagnosis, it's time to talk treatment. And today, the game has totally changed. Endothermal ablation is the new gold standard, replacing open surgery. The long-term results are just as good, but the recovery is way better, and there are far fewer complications. Now, one of the most critical steps in any of these heat-based procedures is using something called tumescent anesthesia. It's basically a cold solution of saline and local anesthetic that we inject all around the vein, and it does 3 jobs at once. First, obviously, it makes the area numb. Second, it physically squeezes the vein, compressing it right down onto the catheter for better contact. And third, and this is brilliant, it acts as a heat sink, drawing away the thermal energy to protect all the surrounding tissues from getting burned. So, the 2 big players in this space are endovenous laser, or EVLA, and radiofrequency ablation, RFA. What's the difference? Well, you can think of laser as being super versatile. It's great for wavier, more tortuous veins, and the success rate is incredibly high. RFA, on the other hand, is a bit more plug and play. It's standardized, it's automated, which can make it a little easier to pick up, and you don't need all the laser safety gear in the OR. But honestly, they're both fantastic options. The choice really just comes down to what the surgeon is comfortable with and what the hospital has.
Now, what if you don't want to use heat? There are other options, the non-thermal, non-tumescent techniques. You've got foam sclerotherapy, which is perfect for those really twisty veins that you just can't get a catheter through. Then there's mechanochemical ablation, or MOCA, which uses a little spinning wire to rough up the vein wall while squirting in a sclerosant. And then there's endovenous glue, which is exactly what it sounds like. It just glues the vein shut. These are really useful tools to have in your back pocket, especially for patients who are terrified of needles.
Okay, Section 5, the classic approach, open surgery. Now look, its role for first-time, uncomplicated cases has shrunk dramatically. But don't write it off. It's still a core surgical skill you have to know, especially when things get complex or when veins come back after a previous procedure. You have to know how to do this. And this right here, this is pure, 100% high-yield exam anatomy. When you're doing a saphenofemoral junction ligation, you have to find and tie off the 6 main branches, the 6 tributaries, to stop the veins from just growing back. There are 2 on the lateral side, 2 on the medial side, and 2 coming in from below. You just have to memorize this slide. No 2 ways about it.
So why do we move away from open surgery? Well, one of the biggest reasons is the risk of nerve damage. When you strip the great saphenous vein down to the knee, you can injure the saphenous nerve in up to 7% of cases. And it's even worse for the small saphenous vein. Surgery there can damage the sural nerve in up to 20% of patients. I mean, those are really significant risks, and the risks we pretty much completely avoid with the endovenous techniques.
And finally, Section 6, recurrence. This is a huge clinical headache and, you guessed it, a favorite topic for exams. What do you do when the varicose veins come back? You've got to understand why this happens.
After an open operation, the #1 reason veins come back is something called neovascularization. It's the body trying to heal by growing new, but totally useless veins in the groin. That's about 40% of cases. Other reasons? Maybe a piece of the main vein was left behind. Maybe there was a technical slip-up the first time. Or maybe a totally new spot started to reflux. The bottom line is, for any patient with recurrent veins, you have to start over with a new duplex scan to figure out exactly what's going on.
And that leads us to our final big picture question. The story of treating varicose veins has really been a journey from the scalpel to the catheter. So when you think about the much easier recovery with endovenous techniques, and you consider that really tricky problem of neovascularization after open surgery, you have to ask yourself, is there any role left for the scalpel in a primary, uncomplicated case of varicose veins? That's something to really chew on as you put all this information together.